अब एक बार लिंक ले लो यहाँ से।
ले आओ लिंक तो
ठीक, और फिर उसको जूम को फुल स्क्रीन कर देना जैसे मैंने किया है, तो फुल स्क्रीन चलेगा। ये जो साइड में चल रहा है ऐसे नहीं दिखेगा।
कर दो ना।
आप व्हाट्सएप पे शेयर कर दो ना,
लिंक तो मैं शेयर कर दूँ।
चैनल आपके पास
मैडम पान सिंह।
Welcome to our podcast, the new thing we have started in our forensic
ठीक है, डन।
conferences, because podcast is becoming trending nowadays. However, it is just like an interview, but the names have been changing, like panel discussions. In that we have discussions, and in podcast also there is interview, there is discussion, but the name has been changing. So I thought like we should have something new, and I hope this helps all the PGs and delegates. And with that, we have eminent personalities with us, and I would like to know them in detail, but in short words. I will start from Dr. B.D. Gupta sir to introduce him and tell something special expertise in his area and the working area he was in.
ओके, शुरू करते हैं। हमारे दोस्त जो पीछे बैठे हैं वो नजदीकी रिश्तेदारी कर लें, थोड़े आगे आ जाएं, है ना? इसमें क्या बुराई है? दोस्ती पक्की, ठीक है। अब मुझे अपना इंट्रोडक्शन देना है, यानी अपने मुंह मियाँ मिट्ठू। अभी मिट्ठू तो छोटा सा शब्द हो गया है, बराबर। मेरी हाइट भी अच्छी है, मेरा वजन भी अच्छा है, तो मैं अपने मुंह मियाँ शुतुरमुर्ग बनना ही है तो मिट्टू क्यों बनूं? बनूंगा तो बड़ा ही पक्षी बनूंगा, शुतुरमुर्ग, ठीक है। तो मैं अपने बारे में कुछ 2-3 चीजें बोल देता हूँ। 45 years of student-teacher interaction, 8 years as a student and 45 years as other side of the table. That is one thing. 33 years as professor. Out of those 45 years, multiple medical legal cases done, witnessed, guided, and so on and so forth. One of my batchmates said that so many titles came and went. So when person is 73 plus and 45 years in academic field, this is going to happen. So that has happened with me also. About 100 papers here and there. One of the papers is quoted by Delhi High Court pertaining to Campos mentis in cases of burns, and then it is repeatedly quoted by High Court as well as Sessions Court in their judgments. So this is what is about me. Thank you.
Thank you, sir. That was.
सर हमारे प्रेसिडेंट भी रहे इंडियन एकेडमी ऑफ फोरेंसिक मेडिसिन के, हमारे सीनियर थे। They are our mentors that we have been looking towards him, that how he is behaving and how he is moving in the academy, and we have learned a lot from him. Thank you, sir.
Yes, actually, it is in short time. We have only 1 hour for hear. I mean, to hear everything from you all people. But to just introduce, you just said few words, but there is much more to tell. I would like to request Rakesh Goria sir to tell about himself in short, so that in podcast we will include his expertise.
So, you see, I am a student and I am a learner and I am a passionate worker. So that is what I wish to tell about myself. And if you want to go ahead in life, always believe in learning, and you will always move ahead in your life. And the things which people mention, they come as a byproduct of your hard work and efforts. So never look toward them, look toward that how you can improve yourself. What you are yesterday, you are bad. Today you should be better than yesterday. So that is the only thing. And if you will improve each day, probably by the end of life, you will be a great person. Thank you very much.
Yeah, sir has been eminent personality in Punjab, Haryana area, and he was a forensic expert. He has a lot of expertise in court cases, forensic medicine, as he taught about nursing also. So he is yes, very eminent. But people don't want to tell about themselves in by their mouth. But yes, sir, I would like to request Satya Sai sir to introduce himself so that people should know his area of expertise.
Hello. Presently, I am working as a professor in Maharashtra Dr. Ullas Patil Medical College. I was working as a professor under Government of Odisha previously 6 years. Then I also worked in Africa as in a post-graduation institute under Ministry of Ethiopia Health Ministry for 1 year. And I was also working in various states, Andhra Pradesh, Telangana, West Bengal, as a faculty in medical college. And before that, I had 10 years of service in under Government of Odisha as a general practitioner. My motto is, my principle is, I am a freedom fighter. I think that India has not achieved the freedom. We have only documentary freedom, but in mind we have not achieved the freedom. And we should establish technology. Then only development will take place. And my principle is, I will not consider the sacrifice of technology for the sake of administration and anything. I don't compromise. So that is why I am moving everywhere, and I will give examples also how technology to compromise, not to compromise technology, how we are facing problems. And this is a message to my next generation that still we should continue with this. We should try to make the technology to reach each and every individual, not to the only people at the highest place. We should not compromise. We should continue as per the Constitution of India, where the right of every citizen, it is not the right of the person who is sitting on the chair. So I have maintained in my lifetime, and I will give you some examples from that work.
Sir,
thank you.
Of course, we would like to know your international experience ahead. Now I request Kailash Dine sir to introduce himself in brief.
I feel little small from all these personalities.
That is
Just I can say, I have experience of doing postmortem personally for 25 years at GMC Aurangabad. Done more than 10,000 postmortems and guided about 15 MD students. And now since last 5 years, I am actively involved in the administration. Initially, I was medical superintendent at GMC Aurangabad, later deputy dean of hospital at GMC Aurangabad, and now since last 2 years, I am trying to establish new medical college of 100 capacity at GMC Buldana, which is near Aurangabad. Now I am having additional charge of dean at GMC Buldana. I am still working and drawing my salary from the GMC Aurangabad only.
That is humility, sir. That you don't consider yourself as big person, but in my eyes, and of course, in many people, they see you as an inspiration. Like Dr. Umesh is there, who is always admirer of you. I know how much you have experience, vast experience of postmortem. Now I would request Tejas sir to introduce himself in brief and.
So thank you so much, Madam. Myself, Dr. Tejas Rajapati. I am working in an academic setting also in Ahmedabad, Srimati NHL Medical College as an associate professor. My key area of interest is toxicology. So I've also started my own diagnostic center in Ahmedabad, Gujarat. That is a unique kind of a first laboratory in India where we are doing the different kinds of tests for the diagnosis of clinical practice. So we are also managing patients, diagnosis patients, and working with many of the industrial, occupational health, and many other things. So hopefully that in case scenarios, we will have discussions from that.
Yeah,
Thank you.
that's nice. We have toxicologist also with us to discuss about toxicology matters. Yeah, that now.
So we do have lots of knowledge and experience sitting here on the stage. and let's start this podcast. So, please.
Yeah. I want to keep this simple and informative as well. So I would like Gupta sir to just tell us about the lessons you have learned in like some challenging cases that you must, I mean, you have learned and you wanted to remember it for your lifetime.
Okay. When this program was planned, I was the original person in that. And fortunately or otherwise, I am here. And time given was 5 minutes. So I prepared one case from whatever little or more I did during my professional practice. And I now narrate the salient features of that case. That case is a landmark case in my life, as well as probably landmark case for so many forensic practitioners. So it was a case of custody death. Death happened somewhere in jail in Amreli, and the case was referred to us in Jamnagar. It happened somewhere in 87. Three of us, myself at that time, 87, I was associate professor and head. And two of my junior colleagues, Dr. Mangal and Dr. Kalele. We three conducted the postmortem examination. This was the only case till then, until now, where the executive magistrate, that side, SDM, literally said that nothing should to be passed on to police. So it was real magistrate inquest, and forensic department dealt with executive magistrate SDM Amreli. We did postmortem, we submitted report, then the case went on for trial. There were two accused, police inspector and sub inspector. Examination in chief. Okay, it was as usual, nothing specific in it. But the cross examination part, it went on for 7 sessions of court, 3.5 days. In my lifetime, I don't know about your experiences. No other cross examination went that long. In other case, once it happened that it was people murder and the 2 cases of that I did. So that cross examination also went on for 1 day, 1.5 session. But here 3.5 sessions court time for my cross examination. Okay, that is part and parcel of our profession. I have accepted it, so I had to undergo this. And as usual, whatever little or more written in our books, now what happens in cross-examination, that happened with me also. So starting from say qualification, credentials, integrity, honesty, and whatnot, everything was explored and everything was scrutinized. There was a lady judge, presiding officer. Now, facing that cross examination for 3.5 days, yesterday somebody said, and I repeat, that it requires guts and grit. During all these 3.5 days, I remained objective, did not show my emotion. I never lose temper. I did not ask for chair. I did not ask for glass of water. Now you see, Indian system, judicial system is funny. Prosecution and cross, defense. They come one by one. They have a liberty to sit. They have a liberty to make any gesture, putting their foot on the stool or bench or taking support of a table nearby. They can make any gesture or anything. But that is not look decent, and that is not allowed, I want to say, for any witness. May it be a medical witness like me, a senior person in medical field, having some 15, 16 years of experience by then, or common witness. Anyway, I went through this. And in due course, the judgment was passed. Both the accused were acquitted. No problem. I don't mind and I don't bother about the judgment. That was not my forte. I deposited my evidence and that's all. That was over. But the matter was not simple for me. In that judgment, the Honorable Lady Sessions Judge put one page remark. I am not going to read it. It is very long. One full page. I thought it is almost a sort of stricture passed against me. Only thing is that she said in this that though defense lawyer requested the chair to declare Dr. Gupta hostile, I am coming short to this, so I am putting these remarks. So these were the harsh remarks. What happened? My family and friends said that this is not good. You should say something for this. And say something in legal sense means I had to put a court in the High Court. I had to put a case in the High Court to remove this paragraph from the judgment. I did this. All right. Ironies of life. We know that this is a miscellaneous case. High Court has so many important things. So my case came on the board in 2013. From 93 to 2013. All right, I filed it somewhere in 1993. It came on the board on 2013. Till then, whatever little or more I had to achieve in my job profile, I had achieved. I was promoted as dean, which I refused. I did not want to go to administration side, and I continued as professor till I retired. My retirement was due in 2014. So I did not pursue the case. So case ended its own death anyway. But destiny has some other thing. एक minute only, sir. Destiny has one other thing. Somehow, later on, one of the relatives of the deceased telephoned me. That sir, हमें आपका जुबानी फिर से लेना है. मैंने कहा क्या हुआ? बोले सर वो केस में हाई कोर्ट ने 2 में से 1 एक्यूज्ड को इंस्पेक्टर को कन्विक्ट कर दिया है. तो हम सिविल केस फाइल कर रहे हैं कंपनसेशन का. तो उसमें आपका विटनेस चाहिए. It was a news for me. It happened in 2023. It happened in 23. Okay, I gave my evidence from America when I was there with my children. That's apart. But when I went through that judgment gave life imprisonment to first accused. That was inspector. Okay, High Court also acquitted second accused. But the important part was, without my knowledge and without my prayer, the High Court bench of 2 judges deleted the paragraph 55, which was in the judgment of Sessions Judge, saying that this is unwarranted and hereby we delete it. So there it all ended. So here I conclude. Thank you.
I want to ask one thing, sir. What lesson are PGs and learners like me take from this case?
I have got lessons also. That when we are going in court, I went in the court on time. All right. अभी मैं आपके सामने खड़ा होता हूँ. यंगर जनरेशन, आप भी थोड़ा सा मुझे देख लें. I am from the old school, and I had gone through the ragging also. So my shoes are black, leather, socks, shirt in, belt, and turn out, clean shaved. I would appear in all my deposition in this form only. I would appear in this form in all my classes only. Without shaving, without a good turnout, I would not conduct a lecture or I would not attend office. I never attended office in sports shoes and so on and so forth. So this is one of the lesson, personality. Then standing upright, be objective, don't be emotional. They are going to instigate you, particularly defense lawyer. When 3.5 days person is crossing on that so-called strangulation or throttling mark without ligature material, then they want something out of this or that. So they are going to instigate you, but yes, we will have to maintain our calm, cool, composure, objective and upright, and at the same time assertive. Many times I had to say to court that this question cannot be answered in yes or no. I require an explanation to submit. So these are the lessons. And of course, whatever I underwent, this is occupational thing. Once I have accepted the post of forensic medicine faculty, I have to go through this. So I can't say that ये क्या हो रहा है मेरे साथ. मैंने लिया है, हो रहा है.
So we understood, sir,
every
that
kind has two sides.
yes, we understood that being objective, being consistent, and irrespective of the judgment, irrespective of the defense and this side cross examination or whatever you should say is your finding and nothing else. That lesson you have taken and you remained with that till your after your retirement also, and you are pursuing that. So that is great lesson. Now I would like to request Goria sir to just tell briefly about his lifetime lesson he has learned from the challenging case he has faced.
There are so many cases, but being time constrained there,
Yes.
so I would like to mention one of the cases where there was a crowd of 500 before the mortuary, and they were saying we will not allow the postmortem examination to be done, and the police is requesting us to do the postmortem examination. So that is challenging. That how you deal with such situations. So I asked from the crowd that who is your front man? Kindly 3 or 5% they can come inside, and we can discuss and see that what best can be done for you. And when they entered, they said that she is our Devi. She is not dead, so we don't want to allow the postmortem. She is still living. And I just took the history that how this happened. That she said that she was having gastroenteritis, and she was taken to a government hospital. And they said that she is dead, and intern was sitting, and he declared the person dead. But when they came back, there was an RMP. So जो दूसरे RMP तो रजिस्टर्ड मेडिकल अनरजिस्टर्ड RMP जो जोला छाप वाले थे, तो उसके गए, उसने कहा शी इज स्टिल अलाइव. कहते because he was having some एक जो पूजा पाठ करने वाला था उसके साथ उसका था, उसने उसको बुलाया, उसने कहा ये बोतल ले लो और ये ठीक हो जाएगी, इसको पानी पिलाते रहो, थोड़ी थोड़ी देर में ये ठीक हो जाएगी। तो वो उसने उसको ले गए, घर में ले गए, सर्दियों का मौसम था, पानी देने लगे और साथ में हीटर 4-5 हीटर लगा दिए साथ में आए कि अभी तो जिंदगी है, इसको कुछ और प्रॉब्लम ना। पानी डालते गए तो सेकेंडरी रिलैक्सेशन हो गई, तो पानी अंदर अंदर भी जाने लगा होगा उस समय बीच में। तो उन्होंने कहा कि ये तो डेड नहीं है, ये तो हम इसका पोस्टमार्टम नहीं होने देंगे उसके साथ। कहते ये तो हमारी देवी है। तो मैंने कहा फिर आपको लगता कि ये अभी जिंदा है? तो कहते हाँ हाँ हम सब मानते जिंदा है। कहते हम तो इसके कहते हमारे ये बच्चा देती है, हमारे को ये बेटा देती है, हमारे का ये सब काम पूरे होते हैं इसके के पूजा करने से। तो फिर मैंने कहा चलो पहले तो ये देखे कि ये वाकई जिंदा है कि नहीं जिंदा है। तो हमें तो पता था कि डेड है, लेकिन कि उनको भी सेटिस्फाई करवाना था ताकि मॉब से आपको कैसे बचना है। तो मैंने ईसीजी वाले को, हॉस्पिटल से ईसीजी वाले को बुलाया। मैंने कहा ईसीजी का एक बंदा जो उनका साथ है, मैंने कहा आप लेटो, आप ईसीजी करते हैं। उसको दिखाया तो मैंने कहा ये देख आपकी वेव्स आ रही है ना, जब आप जिंदा हो तो आपका हार्ट चल रहा है, ये वेव्स आ रही हैं। अगर बंदा ये जिंदा होगी तो इसकी भी वेव्स ऐसे ही आएंगी, अगर ये मरी होगी तो इसकी वेव्स फ्लैट आएंगी। समझ गए? मैंने कहा बाद में कहते हैं यस हम अंडरस्टैंड कर गए। पहले उसकी कराई, फिर उसकी कराई तो फ्लैट आई, तो आपका अब ये तो डेड हो गया। अब डेड है तो पुलिस ले गई तो पोस्टमार्टम तो होगा ही, मगर कुछ नहीं हम थोड़ा सा करेंगे, कुछ ज्यादा तो करना नहीं है। तो आप फिक्र मत करो कि आपको ऐसे मिल जाएगा वापस, कुछ नहीं होगा। अगर जिंदा पहले तो वो मान नहीं रहे थे, लेकिन वो मान गए कि मरी है। फिर पोस्टमार्टम किया तो वो मम्मीफिकेशन हो रखा था उसके ऑलरेडी बॉडी में मम्मीफिकेशन उसका हो रखा था। तो किया, उसको दिया। तो उसकी स्टोरी ये थी कि वो उसको घर पे ले गए और फिर लोगों ने आके पैसे चढ़ाने शुरू कर दिए और उनका तो बिजनेस अच्छे से चल पड़ा कि बहुत आते हैं। 4 भाई थे, चारों भाई आपस में पैसे बांट लेते थे। फिर एक भाई की मदर फादर से लड़ाई हो गई, उसने उनको घर से निकाल दिया। अब उसको घर से निकाल दिया तो वो कहता मैं इसको तो पैसे मिले, वो कहता मेरे हिस्सा दो। कहते नहीं हिस्सा नहीं मिलेगा तेरा, तुझे घर से निकाल दिया। उसने फिर पुलिस को कंप्लेंट कर दी कि मरे हुए हैं, ऐसे ही पैसे इकट्ठे कर रहे हैं इसके। तो ये बहुत न्यूज़पेपर में भी रहा और कई बुक्स में भी पब्लिश था। ये स्पिरिचुअल कोमा, उन्होंने कहा ये शी इज इन स्पिरिचुअल कोमा, शी इज नॉट डेड। तो ऐसे केस भी आते हैं। सो यू शुड नो that if there is a situation, how you are to handle the situation according to the need of the community. कि वो भी satisfy हो जाए और आपका भी।
Sir, I want to ask one thing. What aspect of your nature and personality help you in this case, sir?
Just to listen to others. Just listen to others and don't be angry.
That's sounding so simple, but it is a very great quality to listen carefully.
Communications.
Yes.
Yeah, the most important point in communication is listening. So if you listen well, you will act well. That is true. And you manage the crowd of 500 people over there by asking one person who can listen, and you prove that she is dead. That was the skill you want other PGs to accept that listening, observing the situation and how to deal with the crowd. You should ask one person, the representative, the leader member in the crowd, and explain them what it is. So crowd management was your lesson.
There is another one minute thing that is very, very important. If you give me the time, there was a case of case came, that was case of a murder, but there was.
Yes, sir, we will discuss another case.
Okay.
We will, ask Satya Sai sir that in Ethiopia, what was different thing you experienced apart from India? What you experienced in Ethiopia?
Thank you, madam.
And I want
I'm going to tell about Ethiopia only because Ethiopia was, when I went there, I was thinking that it is one of the poorest country of the world and the standard of people are very poor. But after reaching there, I could find that the standard of postmortem examination we do in our country and they do in their country is totally different. I used to get triple cover dresses, triple protections, gum boots, whatever instruments necessary, whatever manpower necessary. 4 tables we run. I will be sitting on the center of the well, 4 postgraduates for each table. So at a time we take up 4 cases because caseload was more per day, 20 to 30, sometimes 40 also. So we start from morning 7 o'clock until night 7 o'clock. Sometimes we got permission for night autopsy also. So like this, but I never compromise in any routine. My definition of autopsy is same original word. See in your own eyes. Unless I see the cause of death in my eyes only, I don't compromise.
In
That's why
Ethiopia, what was different?
I'll tell madam this case I'm telling you, from that you can understand. So when it was a case of 11-year-old female, she was brought by the police. Police never inquire anything. They will just take away the dead body. If something is found, okay. Otherwise, they will throw without any history. So case was received. I was told that sir, it was a case of sudden death. The girl was sitting in the school, studying in the class. All of a sudden, she fell down in the class. And when I examined, only blood tinge froth was coming out from her mouth. And my routine way is to see all routines starting from dress. So my PGs were telling, sir, we are taking up this case. It will be a sudden death, some natural disease, something, we will finish it. So, but I told, let me see the case. Then when I saw, I just found one drop of blood on the collar, only one drop of blood. So once I find a drop of blood, I must find out what is the reason where from that blood came. Then gradually I found some clotted blood on her head. Only one drop of clotted blood. Then I told something is there. Then we cleaned. It was found like a penetrating wound. Small means 0.3 centimeter diameter penetrating wound. It was visible. Then it was also in my question because no history, nothing is there. School, inside the school. Then penetrating wound means what? Then we continued a meticulous examination, layer-wise examination. It appeared that some instrument somebody has hit our head. It might have penetrated. In that way, I was explaining. So, but once we opened, after opening the calvaria, when I saw from inside, my doubt was established because the typical way of beveling wound was there, inertable beveling. So from there, I was thinking in the way of projectile. But unfortunately, when I removed the brain also, I could not establish any track. But although I found a contusion under that, I thought that some injury might have been limited to only the surface of the brain. Then brain was removed. After that, I was also wondering. Then I found a subperiosteal contusion on the roof of the orbit. So there I reconstructed. I thought, no, something has already come and hit here. And then I again examined the brain myself. Brain was on the table. Then I found a bullet lodged in the temporal lobe on the left side. From the right paramedian side, it has entered, it has hit there, and it has ricocheted. There is no history, and track also I found. Thereafter, meticulous analysis, I tracked also fine. I recovered the bullet itself. Thereafter, all the staff who are sitting there, they started laughing also. This Indian is showing something. Then when I found ricocheted, I just started. Now, projectile is there. So, because it was a sign of ricocheting, subperiosteal contusion. So, it went, and I diagnosed the case because I followed the principles. Unless I see the reason of what I am finding there, I will never give up. This is the way actually. Otherwise, without any history, if there is any history of firing, I could have immediately gone for X-ray before doing postmortem examination. And finally it was found that there was no sound. Somewhere from very distance, somebody was practicing, and a bullet was missing. It has come somehow. Nobody has noticed how it entered to her body. This was a case actually by doing meticulous examination we can reach. Thank you.
Interesting. That was your observatory power, your knowledge, and application of your knowledge to that observation.
Yes,
that was great.
Yes, strict observation and patience is necessary.
Open eyes. You should be present. In that moment itself.
Yes.
Yeah, that was great. And in Ethiopia itself, you created your impression of being Indian, and to that extent, you challenged them and you proved that it is
One
believed.
precipitated labor they did not know.
Okay.
People were arrested. They were in the court of law also. So once I gave the opinion of precipitated labor, their policies are very powerful. They can also interrogate doctors directly. They can directly arrest you also. There is no medical negligence to arrest and all these things. So once they feel that their evidence is going against you, they are finding, they will. But I gave clear cut a precipitated labor. It is not. There is no responsibility of the government. And with my one opinion, it opened up the cases for previous people. Nearly 5-6 persons were released from the jail in 2 months' time.
You released.
Yes.
Wow,
So,
that's nice.
because something like that. Thank you, madam. Thank you.
Nice. Thank you, sir. And yeah, like seeing only one spot of blood on the neck and then going through the like intracranial thing and everything, and you got that bullet. That was commendable. Nice. You want to ask?
Sir, I want to ask again one thing to you. What one good quality or what good thing that we don't usually follow here, you follow there in Ethiopia?
The practice is same. Being technical persons, we must not compromise the technologies. Our examination should be stepwise. I never say expert. For experts, routine is not necessary. This is a misnomer. Because medical science, biological science has so much exceptions. ये लिखते हैं ना क्रोगमैन, exceptions are the rule and stability is exception itself. So for that way we have to go every case routine manner. Routinely, first examination. Sir, you cannot believe police is removing the dresses and bringing the body in our Indian conditions. I clear cut right. Dresses are removed, no comment on dresses. And preservation they bring. Sir, isko preserve करके दे दीजिए. Nothing. I write the police brought the dresses removed and they asked me to preserve. I wrote, there is a sensational case. I cannot tell it now. The case is under crime branch investigation. With this report, all are in problem now. But we cannot compromise. Who are you to remove the dresses? If you remove the dresses, you have to write about the findings on the dress. And we have to observe. So in my places, where do I work? Nobody can touch the body. Once police have given the body, then only I will start the examination. Because some loose things and anything will be there. That are the most important evidences. Once you remove the dress, we lose it. And we cannot go in a particular channel thereafter. So this is why only the following, I always advise, follow the routine properly. Do the work meticulously. Never be hurry in the work.
Starting from head to toe, external to internal, go basic and find the unexpected. That is true. Yeah.
Routine examination.
Yeah.
Thank you, madam.
Now I would like to ask Kailash sir, Zine sir, like with so much of administrative experience in Ghati. Ghati, you call it as government hospital, Aurangabad. So he's working there. You have you have started your own mortuary with cold storage room itself, and then you handled so many disaster cases, and then as a dean, you handled medical legal work also. What did you find in administration? Like, how do you deal with administrative changes, administrative cases in medical legal work and forensic work?
When I started as a forensic person during my PG days, we were taught, or the practice was just follow the rules and continue what is going on. So in clinicians, city hall, the first thing I started to notice as an administrator, city hall is not acceptable. You have to change. You have to find out the gaps where change can be implemented and where technology can be implemented. So unless you move forward with time, there is nothing just continuing everything. It is just there is no difference between a forensic expert and a general public. So that is the major thing. So we try to implement this not only after coming to the administration, but during my in-chargeship at GMCH Aurangabad. So the first thing we started that using computers for writing reports, then using photographs. At GMC Aurangabad, we have more than lakhs of photographs of different types of cases. So all photographs are not taken in a good manner, or what we call it is forensic photography, but we have collection of so many photographs, nearly of all the types of cases. Even I have 2 photographs of cadaveric spasms. So such type of changes we tried. The another change we made, cleanliness in the mortuary. So when I joined there, the cleanliness was not so good. So it was a very small mortuary. Now it is a big one, but cleanliness we had improved. In that small mortuary, we had nearly all the new things there. We have developed our own software, Formis, for entering the data in the central postmortem register, so that the file can be exported as Excel, and that can be stored and accessed by the person for our research purposes. We also improved, say, putting a microscope in the mortuary itself, one research microscope, where we can immediately took some sample on the slide, and in that particular case, we can use it. For example, in case of suspected sexual assault, we can just take a vaginal swab. We can put as a routine procedure. We preserve the samples, but in addition to that, we take that swab and apply to the slide and just seen under the microscope. And in 2 or 3 cases, we could demonstrate spermatozoa in the samples. So that was the another thing is taking say cellotape impression and observing under microscope. Immediately we get if there are any fibers, we can see under the microscope, and we can identify, yes, 2 or 3 fibers are there. So that we had done there. The another important change, I think, which is important, is we changed the perspective of our mortuary servants at GMC Aurangabad. I think our those servants, now we are about 7 people with us, and we are doing more than 2,500 autopsies. To be specific, now this year they are crossing 3,000. This much autopsies we are doing. So there was not a proper working pattern initially, but many of them were of habit of alcoholism. So for about 6 months, we mentored them. Why you are taking alcohol? And to my surprise or to my efforts, they have responded very positively. Now I can proudly say none of our mortuary servants drinks alcohol. I just asked them what you are going to do with this say extra money. Okay, they were that time charging. So it is, I think this is a forum where we can say we are blamed that your mortuary servant, your mortuary people are doing like that. So I asked them just to be, what we call as honest and swabhiman. Oh, you should be very self-reliant person, and self-respect should be there. You are doing work, government is paying you, and you are asking for such a petty amount, and that too you are using it for drinking purpose, and that is injuring your health, your family relations, as well as your reputation in the police as well as, and we arranged one party when they stopped for first month. We all, including say HOD to all persons, were sitting in the hotel on the same table. And that day, the biggest change happened. From that day, they started, and it took about almost 1 year for this change completely to be implemented. And later on, since now more than 15 years are there past, so none of our mortuary servants are alcoholic. The another thing is they have improved their health. After that, they started. I asked them, who is in the mortuary for more hours?
That's wonderful, sir. You have done a lot of good things.
You are there. So you should take uh, proper care of your health. And how it can be taken? We are doing almost 7-8 autopsies per day, sometimes more than 15 also. So when you are doing so much autopsies,
I would
we
like
all,
to-
as a doctor as well as attenders, are exposed to infection, to dirt, and such material. So unless we keep it clean, we will
So
be
we got
infected.
your point, sir. Yes, I would like to interpret here because of shortage of time. Yes, you have vast area of expertise. I mean, as an administrator and being a human, I mean, you are a very good human being. You have done a lot of charities. I have learned. I have heard about your helpings to many of your subordinates and other people also. I have heard about it. And you have
I would like to add 2 things, madam, and then I
We
will
will-
conclude.
Yes.
One thing is, other things, what we started is using this color codes with measuring tape in the mortuary for appreciation of the injuries while taking the photographs. We also bought special 200 grams of that digital balance for weighing these smaller objects like fragments of the bullets. And we also started keeping our this microbiology media in our mortuary itself in the fridge for whenever the samples are to be removed with proper aseptic precautions. We take these samples and preserve it properly and send it to the microbiology department whenever the case demands it.
That's great, sir.
In the 2015, we had a state conference. We just in the conference distributed one kit, medical legal kit, which included one magnifying lens, measuring tape, one glass marking pencil, and the color codes. So that was.
I would like to have that, sir. Sorry to interrupt, but we have to give the
Yes,
time, sir. That is wonderful, sir, that you have prepared medical legal kit, and I would like to have that one kit which you had prepared, color coding and having microscope in mortuary itself, having medias in your mortuary, and then having a cold storage. I want to tell you that in Aurangabad there is a big room which is cold, like they can put hundreds of body in that room. So they have developed that, and lot of things he has done in his department and in college itself. So I salute to you, sir. Now I would like to ask Dr. Tejas about his toxicology management. Like he has diagnostic lab himself, and he has done diploma in toxicology. So like many of the PGs and many of the faculties are discussing about toxicology application. Like we are qualified in MD forensic medicine, but in Maharashtra and other areas, forensic medicine and toxicology is being written. And in my experience also, I am practicing consultant toxicologist. So, and that degree helped me, MD in forensic medicine and toxicology, to practice pharmaceutical toxicology. So, I would like to know about you, like your experience, how you managed that much to go to that extent, and helping in disasters also. Like your experience is quite vast. I would like to know that.
So thank you so much, madam, for this introductions. And yes, I've been there for managing poisoning patients since many years. And whatever that you have read it out in the books, I always used it in a day-to-day life. Suppose if you are talking about antidotes, I'm using antidotes very frequently. Started using antidotes enough times and everyday patients. So there are many challenging patients. Actually, if you're really been treating this kind of a poisoning patient, the poisoning patients to diagnose is really been very challenging in a clinical practice. Because whenever the patient comes and patient used to tell you that I've ingested this much of compound, you have to believe it. Even at present, if you can search it out anywhere in India, where you just want to send the samples for the confirming the diagnosis. So even on organophosphorus, the patients of pesticides, when ingested pesticides, comes to the hospital and they are saying that I've ingested some insecticide. I don't know which insecticide or pesticide. We usually believe it is an OP compound. So what we are going to start it, we are just giving the atropine or palm or whatever that's in our mind. And even the atropine and palm, we don't know the dose. What dose that we should give. The palm, what we are teaching the students is also gather that 2 gram 8 hourly, 1 gram 8 hourly, 2 gram 6 hourly. WHO that has clear cut recommended that 500 milligram per hour continuous infusions. What about atropine? We never taught properly to the PG students that when to end atropine. When to give atropine, we know, but when to end atropine? Because many times we all know that when the patients of organophosphorus been treated, they have been tied to the nodes and to the cots because of atropine-induced deliriums. So there are so many challenges that what we are facing in a day-to-day life. Even a snakebite patients, we are getting many interesting cases. But I would just like to discuss only 1 or 2 cases what that makes me challenge while we are having this kind of one lady, where a young lady where he was actually is a very well-to-do background. She wants to commit suicide. She put some cuts on the radial cuts, very superficial cuts, little bit of blood loss. Little bit of then she was trying for the hanging from the asphyxia, but she didn't able to do it. Then she presented to the casualty with the severe hypotension, metabolic acidosis, little bit of ECG was showing arrhythmia. So the critical care specialists, they were like that in dilemma that what happened to her, because that was not that much of blood loss or the hypoxia that may lead to this kind of complications. So they called me, Tejas, what is your thought on that? And I was seeing also that patient, but I was also surprised that this has really been very surprising, because they put on Lyle's tube also, they were suspecting some of the ingestion, but there was also no any foul smell or any other, but the findings are more on the something which is unusual that she may have consumed. While after just I was coming out, I just asked the nursing staff to look after private parts. She puts aluminum phosphide tablets into the vagina. So the alphos was absorbing from the vaginal mucosa, and she was having aluminum phosphide poisoning from that point of putting her to the death. But fortunately, we could save her. There are many other cases where, there are few cases from Delhi where the entire family was having some problems. It's again a very billionaire family, and they have a severe hair loss. And one of the younger daughter was having a lower limb weakness, and she was admitted to the hospital. Within 17 days of a treatment in the hospital in Delhi, she died, unfortunately. Rest of the people, the father, mother, and the other elder daughter was admitted. She was married. All of them have got a similar kind of a weakness and hair loss, but they were not able to identify what went wrong to this family, because of the entire family was affected. And someone connected me from Australia from their relatives, and I was coming to the picture, and I just asked for the neurophysician at Delhi to look after the metal tracings. So, because I was suspected then maybe of arsenic, maybe the culprit of this kind of an activities. But I was surprised when I got the reports from Dr. Lal Path Lab, and it was on thallium exposure. So thallium, yes. So it was on thallium exposure, and it was very high thallium. And we all know that thallium is a radioactive substance that is not get easily into the market. It is very difficult to get this kind of substances, but they may have got this pharmaceutical background, so they may access to this thallium at the time. Important thing for me is to how to treat them, because whenever this kind of an so I'm also resource faculty with the NDMA, National Disaster Management Authority. We are giving training to the Indian armies and other people and Airports Authority of India. So we have got a good connections with the DRDO. So at that time, Prussian Blue was into the pipeline. Prussian Blue is antidote, you all know. So I just have a call with the DRDO INMAS director, and it was also in Delhi, and the hospital, the patient was also in Delhi. And we used this Prussian Blue as an emergency use. So as an antidote to treat this thallium exposures, but unfortunately we could only save the father of this family. and that was given by the son-in-law to entire family. It has later on been caught by the police also. There are many of the cases, where we are been very much, been handicapped. So you can't do anything, what to do next, what not to do next. Because there are so many complications or challenges that may arise. Just 2 days back, I got one patient who have ingested Sindoor, that is a lead tetroxide, we all know that. And he was a layman person who have ingested that. He presented with acute renal failure. And the intensivist are now, you are asking, madam, that how that we can help it. The intensivist was in hurry to, give the Saxima as a chelating agent or D-penicillamine, whatever that is available in the market. We never know that what chelating agents are available in the market. So he was hurry to give this chelating agents to chelate this lead because the lead amount was very high into the blood, which can cause this acute. He was anuric, but he don't know why that we want to use this chelating agents. Because the chelating agents will chelate and ultimately the route of excretion will be through the kidney only. But he is anuric. Then why you want to use this chelating agent and present? We have to be wait and all that. And he was like that, nahi, this is a medical legal case, कुछ हो गया तो क्या करेंगे? अभी तो अपने को देना ही पड़ेगा. अगर नहीं दिया तो ये मर जाएगा. So we don't know. I would like to tell you that there are so many chemical compounds, we don't know which are the hemodialysable. We every time, when the patients comes to casualties or the emergency for any kind of a poisoning patients, we heard that the force alkaline beverages, hemodialysis, ye kar diya, wo kar diya, but even after that, we don't know that that should be done or not. Very frequently, commonly nowadays, the herbicides, that paraquat, which is coming into the market, no treatment, but so most importantly, we should not give oxygen. We should not give oxygen to this patient. Yes, because oxygen will act as a carrier for the paraquat to damage the lung tissues. And many times we are getting the patients from the primary care that they put the patients on ambulance, put the oxygen first. So there are many things in poisoning cases that I personally feel if you are going to attend my sessions tomorrow, it will be more. So I think that we have to be very sure about the treatment and algorithms, whatever that we are going to do. I had also started small, as I told you, madam, that the laboratory facilities, diagnostic facilities in Ahmedabad, Gujarat, so that I'm dealing with this kind of an occupational health also, as well as for the dual.
Yeah, I wanted to ask that only. What are the like things you have given in your setup to start private toxicology laboratory? Like, is it helpful in small areas also, or just in big area?
No, yes,
like in Ahmedabad?
there are so many things that at present in a phase 1 manner that what I started, we are looking after the blood or the biological fluids, the blood, urine, gastric aspirates from the clinical patients. We are only doing for the clinical patients. And also the other aspect is occupational exposures. Occupational exposures from the industries where the workers are working. According to the Factory Act, they have to do this periodic medical examinations every 6 months, 3 months, or every yearly. So we can also have this kind of a biological monitoring system to be established in our laboratories. Second phase.
I just wanted to know, like, you have established for clinical and this occupational exposure also. So you have all the instruments in your laboratory, like what we have in FSL, or you just 2-3 instruments? You have?
No, at present, instrumentation, if you were talking about, we have a few instruments, not all the instruments, what the bigger industries may be having, or institute may be having, because see, to have an instrument is not a big issue, but to run the sample is really been a very difficult task, because to have an extractions methods to be settled down from the blood or urine or other matters, it's still been very challenging sometimes. Because I just share you one few example, because I've been called in Akola in Maharashtra, where the very many farmers been affected with the inhalation of these pesticides. And the government have called me and ex-FSSI director over there to have look after, because the Yavatmal Medical College was having separate poisoning ICU. Dr. Manish Igrivar was the dean at that time in Yavatmal. So when I was called and Dr. Kanungo was called, we went there to have the medical protocols, because those who are dying or those who already died. In a post-mortem examination, we didn't find anything because they have got inhalation exposures. So the political pressure was like the doctor were treating wrong because it was not an organophosphorus or pesticide exposure, but still they are giving atropine or palm or something. And there were an allegations from the treating doctors. So what to do, what not to do. So even at that time, they have sent this clinical samples. When the patient admitted, they have sent the samples to the FSL, NIOH, AIMS Delhi, and many other things. But we have to understand the pesticides are metabolized so fast in our body. So you will not able to identify the original pesticides. You have to do so many extractions methods. So to have an instrument is really been good, but
you extracted in that time, like farmers, you said?
no, at that time we have not started.
Okay.
We just started 1 or 2 years back.
Okay.
So it is a matter of I think 3-4 years back.
Okay.
So at that time, even not a single institute in India, they were able to identify the pesticides from the blood or the urine of that exposed people. So my take-home important message is that it is not important to have an instrument. It is important how that you are looking after this kind of an toxidromes as well as the analysis technique, and then you can go further. And simultaneously, not only the identification is important, I personally feel that you should also guide the treating physicians that what kind of an antidote should be given and when to give and when not to give. Recently, I have got 3 patients in Raichur who have been exposed to acetonitrile. Acetonitrile, we all know that is being converted into the cyanide in our body. So they have been shifted to NIMS, Nizamuddin Institute of Medical Science in Hyderabad, but they don't know how to get the anti-cyanide kit to treat this kind of patients. They were writing down the sodium nitrate should be given, sodium thiosulfate should be given, amyl nitrate should be given, but where to get it? No one knows. In entire Hyderabad, it was not available. So when that company's vice president knows me, he called me, Sharad Reddy ke Tejas, I know I want this kit. मैंने बोला मेरे पास है, but how to give it to you? That will take another 1 day or 2 days. So, but when I reached there the next day morning, when I see the patient, so I feel that was not an indication to give these kits. It was very mild exposure. We have to also understand these important areas in toxicology. It is not that much of easy.
Yeah, that is what I wanted to understand. Yeah. Like what things you give in your report. Like you do qualitative, you do quantitative also, and then you analyze the
tagline in the diagnostic centers, madam, is that you do the testing which will help in your management. Okay, if suppose some patient have ingested alprazolam, suppose benzodiazepines, maybe a female sometimes, recently I got one female who had taken 200 tablets of alprazolam. So we have to believe that she had taken it. Maybe over 2 or 3 days later, she may tell you again, no, I just want to afraid my husband. But we have to at the time believe. Now, important thing is that whenever that you are dealing and when you are going to send the samples for the serum benzodiazepines level, whether that will be affect in your management, treatment, whether the serum benzodiazepines level 10 or 100 or 200, it will be not affecting. So don't waste your money, energy to diagnose in that kind of patients who does not help you in your management. Suppose someone have taken paracetamol overdose and I really want to know the paracetamol level, that really makes sense because you want to give N-acetylcysteine after having a paracetamol level. Otherwise, the patient may have got a severe liver injury which will be irreversible. So like that, you have to understand in your mind which are the important methods of the testing that you want to develop in your diagnostic centers.
So you mean to say that you are doing consultation to deal with the clinicians and all these things. Not exactly you are running this toxicology lab. You are doing consultation for clinicians and other occupational exposure things.
We are also doing diagnostics. We are also, what I told you, madam, that we are doing diagnostic, but suppose the patient admitted with the pesticide injection, we will do only RBC cholinesterase and plasma cholinesterase. We don't want to do which pesticides.
Actually, I wanted to just, because people are sitting, PGs are there and they want to private practice in after doing MD forensic medicine also. So like private postmortems बहुत ही rarely और बाहर ही होता है, तो वो नहीं कर सकते हैं. बट मेडिको लीगल प्रैक्टिस जो करते हैं वो भी 2-3 या 4 लोग करते हैं एक सिटी में. तो जैसे टॉक्सिकोलॉजी भी एक ऑप्शन है, और आपने जब बताया तो मुझे लगा कि हम पीजीज को भी ये बता सकते हैं. तो आई वांटेड टू नो अबाउट दैट फ्रॉम योर माउथ, दैट हाउ यू आर प्रैक्टिसिंग एंड हाउ दे कैन डू.
Yes, as I told you, I'm practicing. जैसे हम लोग सारे हॉस्पिटल्स में ऑल ओवर इंडिया में whenever the patients are poisoning admitted, there is also cross reference to me. Okay, you just come and see the patient, and I have to write it down the treatment protocols. Okay, so whenever this kind of patients admitted to any of the hospitals in Gujarat or outside of Gujarat or any other industrial exposures, I have to go there, I have to see the patients, I have to write it down the treatment protocols. If I want to do some diagnostic facilities, I will send it to my lab or any other labs which is available. I will send it to them. If it is follow-up references required, I will do it. So that is what I am practicing.
Things actually. One is antidote cupboard and one is poison information center. इसका आपसे कैसे actually how they are helpful to you? Do you maintain one antidote cupboard of yourself? कोई कहीं से पूछ लेगा तो आप उसको अवेलेबल करा सकते हैं. इसके बारे में थोड़ा बताइए.
Yes sir, actually sir, if
practical things what you are.
Yes sir. Sir देखिए अभी क्या हो जाता है कि जैसे chelating agents है, we taught our students many a times from the books that BAL or DMSA, DM or Succimer or whatever the chelating agent, penicillamine. But we have to understand and we have to see that which are the actually available chelating agents in India and which is very safe. So, out of all the antidotes, if you want to talk about, because most of the time, even the clinicians, emergency doctors, they have got a doubts in their mind, what is the antidote of this poison? They are not focused on the treatment protocols, but they have got a antidote identifications always. Only 16 or 18 antidotes which are very specific to this any of the chemical compounds. That is like atropine, oximes for the organophosphorus, chelating agents में जैसे Succimer is a very good oral chelating agent. Okay, penicillamine is not, it is up there, but Succimer is quite effective and which is have got very less side effects. If I'm going to have a ball and if I'm going to have a patient of, because most of the time nowadays what we are getting patients of Ayurvedic treatment ends up with the lead poisoning. Okay, so whenever we are treating this kind of patients of Ayurvedic lead poisoning, मैं उसको बोलूँगा तेरे को बाल लेना है, everyday 4 injection, very deep intramuscular, एक दिन भी नहीं लेगा. Succimer is very quite effective source of a treatment. There are other, if I'm going to have flumazenil for the benzodiazepines, fompazole is also nowadays available. Fompazole nowadays, recently have been used in 16-year-old patient in Ahmedabad with the spurious alcohol ingestion for the fompazole. Very, very useful. Very useful. Fompazole is really, that is what I'm telling you. So furious alcohol was there. So as I'm from Gujarat, I cannot say the methanol at present. So, pardon? Naloxone, sir, see, naloxone, naltrexone, these are all, even flumazenil, these are all the short toxicodynamic antidotes. That is a diagnostic antidote, you can say. Recently, I have got one patient who had ingested opium in a very large dose, and he was like a very religious person. So long beard and all this thing, we have put on ventilator. So that he's उनके सारे जो भी लोग थे वो लोग बोल रहे थे कि उनका बियर्ड का एक बाल भी कट नहीं होना चाहिए. वो उसने बोला कि यहाँ पे वो स्टिकिंग प्लास्टर नहीं कुछ नहीं कट होना चाहिए. So once we have not given put on ventilator, we just give the naloxone for one patient, one trial, and he wake up. So many times these are the very important diagnostic, but we have to be very sure that, as I told you, recently, yesterday, I got one patient admitted in one of the hospitals in Ahmedabad and he had taken antidepressants or the antipsychotic drugs mocktails. Suppose some patients have taken benzodiazepines with tricyclic antidepressants, and I want to, because that patient is in coma, in deep sedations, put on ventilator, and the doctor is asking the flumazenil should be given as a benzodiazepine overdose. So it should not be advisable when the patient have taken something injections with the tricyclics, because the flumazenil can aggravate the arrhythmias if the patient have taken the tricyclics combinedly. So these are the important things when you are going to utilizing the antidotes in a better way. As I told you, why if I want to use the anti-cyanide kit in any kind of an cyanide patient, I have used many a times. It's an anti-cyanide kit which is available in the amino nitrate in the inhalation form, then sodium nitrate and sodium thiosulfate. The basic.
You have so much of, depth and well of this toxicology substance in you. We would like to discuss this in more when you will have your presentation tomorrow. He is going to have a presentation on occupational toxicology. So we will discuss about the things going on around here, sewage gas and everything. I would like to discuss more about this in further sessions, because we have podcast of 40 minutes duration, and you people have given so much of girth to our discussion. Everybody has your unique experience. Anything else you want to add in one sentence for all the delegates sitting here, the PG students? In one sentence, if you want to say something, what will you say, sir?
Always do a complete dissection, because we are seeing cases that they can find out the cause of death and body coming for board examination.
Complete dissection.
They have not opened the skull and the cause of death is lying there.
Right.
So always have the complete dissection.
But in one sentence, sir, if you want to say something to the audience, what that one sentence would be?
Our post, whatever we hold, has other side also, and that is teaching. I want to say that committed to your teaching also, your students also. So you can produce good graduates as well as good proposed graduates. Thank
That is
you.
most important thing. This for the senior delegates over here. Yes, this is most important.
My message is, I always say forensic medicine is the crown of medical science. Once you have the knowledge of rules and regulation of how to practice, then nobody in this, no constitution, no legal rights are there to challenge a doctor, provided you have performed according to rules. So unless you know the rules and regulations, you perform, you become a victim. But once you know the rules and regulations, you will do whatever you like. And I have done in my life.
Yes.
I am not bothered for anything, only follow the forensic medicine rules and regulations. That's all.
Forensic
So
medicine
it
is
the
an
crown of
umbrella.
medical science.
For medical practitioner, if you know forensic medicine, it becomes an umbrella for your defense, or for all the things. Yes, sir.
So
Zinesh sir.
only king wears a crown. So once you have crown of
Once-
forensic medicine, you are a king in this profession.
King, yes,
That's
sir.
right.
Yes, sir.
Thank
It is a crown.
Sir.
Zinesh sir, one sentence for the audience.
I think forensic medicine teaches us to adopt the responsibility in every sense. We should not do, say, case of RTA or just don't take anything as casual. Be responsible for each and every case, whatever medical legal work you do, and I think that is the only thing we can adopt.
Sir, Tejas sir, you have said so many things and we wanted to hear you further, but just in one sentence, if you want to say to the audience, forensic medicine as well as toxicology point of view, what would be that?
Yes, madam, just I want to say all the PGs over here that our branch is not only restricted after death, it is to save the lives also. So come and join the toxicology part also, so that you can be there to save the lives also. And I've been very feeling myself fortunate to save the many lives till now. So that's another part of our subject. So you can do it.
Yes, that is very important thing. Whenever we go somewhere, somebody even says, I remember you because of that. So all the time we have that privilege being a doctor कि हमने किसी की जान बचाई. ये feeling जो हमारे लिए होती है बहुत ही अच्छी होती है. फोरेंसिक मेडिसिन में आने के बाद जो है हमारे साथ वो फीलिंग धीरे धीरे मिस होने लगती है आफ्टर MBBS, बिकॉज हमने किसी की जान बचाई ये नहीं रहता है, बट बीइंग एथिकल, बीइंग समथिंग एल्स, आई मीन लाइक डूइंग समथिंग एल्स, इफ दैट ब्रिंग्स laurels to us, that would be much beneficial. And yes, as you said that in toxicology area, when you say that you are saving lives, it becomes again a big thing. Teaching, I mean, yes, all of you have given such nice lessons in your real life, and that has been very enlightening. I think it was interesting for you all also. So I feel like this was good session. I hope you enjoyed too. Thank you so much, all the respected dignitaries, and of course, you are eminent in your fields. I give much gratitude from my side, from my team, from the organizing team, and I would like to conclude this podcast.
Thank you, sir. Thank you. Thank you very much.
क्या सेव करना है?
नहीं, इसको तो कर फार्मेसी का YouTube